My name is James McLaughlin. I'm a paramedic firefighter with Black Forest Fire Rescue. This is my partner, Travis, who will be assisted today by Stephen Buckner, paramedic firefighter with Tri-Lakes Monument Fire Department. Today we're discussing imminent delivery. The first thing we need to talk about are the indications of imminent delivery. The three things you want to look for that indicate imminent delivery are ruptured membranes, an urge to push, and crowning. So the first thing you want to do is ask the patient, "Ma'am, have you had an abnormal discharge from your vaginal area, say a large rush of water or something of that nature? Ma'am, do you feel like you have an urge to push, bear down, or have a bowel movement?" And then the last thing you want to ask the patient is, "Ma'am, I need to check to see if the baby is starting to crown. Can I expose your lower abdominal area and your peritoneal area and take a look?" Okay? When doing this, you need to move the patient to a personal and quiet spot and then let the patient know, "Ma'am, I'm going to lift up your gown," okay? And we're going to check the peritoneal area. And here you can see presentation or crowning of the baby's head, of the infant's head, through the peritoneal area and through the vaginal opening. Okay. Once you have those indications of imminent delivery, you need to make sure that you move the patient into a functional but quiet area that protects the patient's privacy. Okay? Once we move the patient into that private area, I'm going to call paramedic Buckner in. I'm going to have him establish an IV for me and place the patient on high flow oxygen. While paramedic Buckner is doing that, I'm going to ask the patient a few questions. "Ma'am, how many previous pregnancies have you had? How many live births have you had? Have you had good prenatal care? Are there any expected complications with this pregnancy? Are you taking any medicines? Do you have any allergies to medications? What kind of medical history do you have? Do you have diabetes, high blood pressure, or anything of that nature? Is there anything else that we should know about this pregnancy?" Next, we're going to go ahead and prepare the mother for delivery. And we're going to have Travis step in and begin to coach the mother and help her understand what's going on and what we need her to do. This step is very important. If you can keep mom in control and have her do what you need her to do, it will make the delivery safer and more productive. So now that we've determined that delivery is imminent, we need to get our body substance isolation on. Okay? So I'm going to apply, anytime you're delivering a child, you want to make sure to wear protective eyewear and gloves. It's also a good idea to utilize a gown, as deliveries can tend to be quite messy. The next thing we need to do, once we have our body substance isolation applied, is we need to reposition the patient for better position of delivery. So my partner, Travis, is going to step on the other side, and we're going to move mother down so that her buttocks rests on the edge of the gurney. This can also be accomplished by putting the mother on the gurney backwards in the back of the ambulance so that her backside faces the tech seat. Down just a little bit more. There we go. Then we're going to hang mom's legs off the side. This is a common position, and we're going to make sure that mom's moved into a quiet and personal private space. All right? This is the position that's called the C-curve method. This is the most commonly used position for delivery in the United States. What we're going to do is mom will go ahead and guide her legs up during contractions. Okay? Now we need to get the rest of our stuff in position. So we're going to grab a seat and the cart. And we're going to drape sterile dressings over both of mom's legs. And over her abdominal area. And we want to basically maintain an aseptic environment for delivery to reduce the risk of infection for mother and for baby. We're going to put some padding under mother's head, and then Travis is going to continue to talk to mother throughout the delivery process. Now, as we head into this phase, because we have crowning, I want to apply gentle pressure to the baby's head to prevent an explosive delivery. When doing so, I also want to prevent putting pressure directly over the fontanel area of the baby's head. Okay? So as I'm applying this gentle pressure, and I feel another contraction coming on, Mom, and so Travis is going to instruct Mother to take a deep breath in and push for 10 seconds. And the delivery process will include, we want to try and get about 3 good 10-second pushes in with every contraction, with deep breaths in between each push.
All right, ma'am, we're going to need you to take a real deep breath and push when I tell you to. All right, take a deep breath and push.
Push, 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 push. Okay. Now I'm going to slide my hand. Keep going.
Push, push.
All right. Now I'm going to slide my hand in up around the neck area. And what I'm doing here is I'm checking to see if the cord is wrapped around the neck, if the baby's presenting with a brachial presentation. And I do not see a cord around the neck now. If I did see a cord around the neck, what I would need to do is have Mother stop pushing and have the coach, and this is where a coach comes in handy, the coach would instruct Mother to take deep breaths and use panting breaths.
Okay, ma'am, we're going to need you to take a deep breath and just kind of pant like you're a dog. Just.
All right. And as he does that, I'm going to try and work my fingers in and around the cord and gently, without using too much pressure because I don't want to tear the cord, I want to gently pull the cord from around baby's head. At this time, if I can't do that, or if there's multiple wraps around the neck, I may have to take each one off one at a time. If I still can't do it, then you need to follow your local protocols on the most appropriate way to deal with a cord that is too tight to pull around the head. All right? Now that the head is completely delivered and the body's started to turn, I'm going to support the head and neck, and this is the perfect time to grab your bulb suction and begin to suction the baby's mouth and nose. Now we suction the mouth first, and you remember that because there's one mouth and 2 nostrils. So we're going to squeeze the bulb syringe, then introduce it into the mouth, and then suction on the way out. And then squirt the secretions on the ground, and then do the same thing in the nose. Same on the other side. And if you're nicer than me, you can also do it on the side of the barrier that you have set up. Then you're going to set that off to the side, and as another contraction comes, you're going to deliver that anterior shoulder first. By supporting the neck, you're going to put slight downward pressure on baby so that anterior shoulder delivers. There we go. So we're going to deliver that anterior shoulder, and then after we deliver that anterior shoulder, we're going to bring slight upward pressure and deliver that posterior shoulder. Now, once both shoulders are delivered, the next part comes pretty quickly. So be careful and hold on to baby well. And then immediately upon delivery, the best thing you can do is place baby right onto mother's belly, making sure not to pull pressure on that umbilical cord. Okay? Once baby's there, resting on mom's abdomen, you can then take your clamps, and the first clamp is going to be placed about 10 centimeters from baby. Okay? And then close it. And then you're going to place the second one about 5 centimeters away from the first. Now, we're not going to close these because this is a scenario situation. But in real life, we would close these clamps completely. Then we're going to take our scalpel, and we're going to remove our safety shield from our scalpel. And then in between the 2 clamps, we're going to cut away from us and away from mom, severing the umbilical cord completely. This will then immediately go into a sharps container. So now that baby is delivered and the cord has been separated, we need to warm, dry, and stimulate baby. We start by taking a towel and removing baby from mom's abdominal area, supporting the head, and we vigorously warm and dry baby. By using good friction, we're stimulating baby, and we're warming and drying baby at the same time. Okay. This is a great opportunity to suction baby's mouth out again. So again, we start with the mouth, and we suction on the way out, and again, and we suction on the way out, and then with the nose and the other nostril. Okay, and when we're done with that, if we have a cap that should be in our OB kit, we can place the cap on baby's head, and we can swaddle baby. If baby's still not responding well, another thing we can do is place baby on mom's abdominal area, and we can actually tap the foot and stimulate baby that way. Once we get good response from baby, we can get our 1 minute and 5 minute APGAR scores. Then we can swaddle baby up, support baby's head, and then give baby to mother and allow mother to put baby to breast. Then we can refocus our attention on mother. Okay? At this point, we also want to record delivery time. And as we focus on mother, we want to look to see where the placenta is as far as, are we ready to deliver the placenta? We also want to check for signs of peritoneal tearing. Peritoneal tearing is a very common complication with childbirth. And you often see tearing to the lower part of the perineum, the upper part of the perineum, and to either side. So if we see tearing and we see outside bleeding associated with it, we can take a feminine pad and apply that to the area and provide gentle pressure to that area and control that bleeding in that manner. Okay? As contractions return and mother prepares for the delivery of the placenta, we can grab a biohazard bag and assist. Now, what we don't want to do is we don't want to pull on the umbilical cord. Pulling on the umbilical cord can cause the placenta to disintegrate and actually cause significant bleeding inside the uterine wall. So whenever we want to make sure that we avoid that. Okay? And we just want to assist with the delivery of the placenta, and the delivery of the placenta pretty much happens on its own. The uterus is very effective at delivering the placenta. So as that placenta is delivered, we're going to look at it, and we're going to check for signs of disintegration of the placenta. We want to make sure that the placenta is whole and intact. This is especially important with prolonged deliveries or with patients that are overterm. So then we're going to set that off to the side, and we're going to focus our attention back on mom. It's very common to see a little bit of postpartum bleeding and some vaginal bloody discharge associated with the delivery of the placenta and shortly after the delivery of the placenta. If we continue to see excessive bleeding, we may want to make sure that baby's on breast, because that will stimulate the nipples and increase production of oxytocin, causing the uterus to contract and decreasing bleeding. Another thing that we can do to help control bleeding after the delivery of the placenta is we can do some fundal massage. Okay? And fundal massage is accomplished by taking both of your fingers on your dominant hand and placing them on either side of the bottom part of the uterus. That will be just above the suprapubic bone. So you place your fingers on either side of the bottom portion of the uterus, holding the uterus up in place. This is important because when we start putting downward pressure, we could cause the uterus to exit through the vaginal wall and through the vaginal opening, and we don't want to do that. So we'll hold pressure on either side of the uterine wall on the bottom half. We'll make a fist with our other hand, and we'll bring our fist down into the abdominal area until we meet resistance. And we're going to feel a hard formation at the bottom portion of the abdominal cavity. And as we come down into that, that's the top of our uterus. And we're going to use gentle rocking, massaging motions. And it's going to be a little uncomfortable for mom. And just explain to mom what you're doing. Ma'am, you have a little bit of bleeding, and we're going to control that uterine bleeding by massaging the fundus, or the top part of your uterine wall. It's a little uncomfortable, so take slow, deep breaths and have their coach work with them to continue breathing. And so you're going to do that fundal massage. And you're going to do that for about 30 to 60 seconds at a time. And then reassess, look for the amount of bleeding that you have coming out of the vaginal opening, and that uterus should start to contract and become much smaller. Okay? If that does not control the bleeding, consider more aggressive methods. Consider having mother utilize nipple stimulation, have mom grab her nipples and manipulate her nipples to increase the release of oxytocin. If none of those methods work, consider utilization of Pitocin to control the bleeding. This concludes the scenario for a non-complicated delivery.